Start. You can start.
Start your presentation, ma'am. Hello.
Just a minute, ma'am. I think they are lost. She'll just join again.
Hello. Tejni, what happened?
Dr. Neha, I think she got lost in with the connection. She's joining back, I guess.
Okay. Is it live now?
Yes, yes, yes.
Okay. Request everybody to open the cameras, please, and keep the mic on the mute.
First, we will introduce ourselves. Or is it required or not? Radhika garu.
Madam, Dr. Neha will introduce, ma'am.
No, regarding our case presentation.
That's what Dr. Neha will start it.
Okay.
Srilakshmi, madam, are you there?
Yes.
Yeah. Okay. Dr. Neha, you're back to the connection?
Yes.
Okay, fine. You can start off with the introduction about the case and about the moderators.
Okay. They're live, no? On YouTube.
Yes, yes,
yes.
Yes.
Good evening, everybody. Welcome to an interesting series of case presentations by Shankara Academy of Vision. We'll be starting off with this series with an important case which we see commonly clinically as well as for exam, which is pseudoexfoliation glaucoma. We are very grateful to have with us two esteemed professors, Dr. Maleshwari ma'am and Dr. Sri Lakshmi ma'am, who are senior consultants glaucoma from Shankara Eye Hospital, Guntur. This is Dr. Shifa, and she'll be presenting the case along with me. I'm Dr. Neha. I'm primary DNB first year, and Dr. Shifa is post-diploma DNB first year. Thank you so much. And ma'am, can I share the presentation?
Yes, go ahead.
Radhika ma'am, could you please make me the host so that I can share my slides?
Yes, yes. Just a minute.
Ma'am, is my screen visible?
Yes, doc.
So our patient is a 62-year-old male who is a farmer by occupation, hailing from Kundanhalli, Karnataka. He presented to the hospital with the chief complaint of diminution of vision in the left eye since 1 year. The patient was apparently all right a year ago when he noticed diminution of vision in the left eye, which was gradual in onset and progressive in nature, and it was painless. There was no history of using glasses, no history of using any eye drops to the left eye, no history of redness, watering, photophobia, no history of seeing colored halos, no headache, nausea, vomiting, and no history of ocular injury to the left eye. Past history. The patient had a history of trauma to the right eye around 8 years back with a wood stick, following which he developed pain and redness and gradual diminution of vision, for which he took medical treatment from a local hospital for a few days and then was brought to Shankara Hospital where he underwent an ocular surgery. The patient had reviewed a year later and an intraocular injection was given.
Neha, go back to the first slide.
Okay.
Go back to the first slide. Yeah. What is the importance of the age and sex here?
So certain conditions are more prevalent in different age groups and different genders. So by having an idea of the age and the gender of the patient, we can have epidemiologically we can think of different things.
And what is the importance of the place and occupation?
The occupation, certain conditions are more common in certain occupations, and because the risk factors are associated with them. For example, farmers would be more exposed to sunlight and they have more outdoor work. So things like pterygium and certain forms of glaucoma, certain other conditions would be more common in farmers. And the location, certain places uh, would have a higher incidence and prevalence of certain conditions. So we take that history too.
Next slide. So here, why you are asking about the colored halos and all? What are the conditions you will see colored halos?
Colored halos is seen in glaucoma, cataract, and it's also seen in conjunctivitis. So
So how do you differentiate the colored halos between all those conditions?
we
And
can
all
do
those?
a FinCam test, which is using a stereoscopic slit of around 2 millimeters. When the slit is moved across the eye, we see that the patient sees a color halos are breaking, which is more common, which happens in cataract. However, in glaucoma, the colored halos don't have breaks in them.
In glaucoma, what happens?
Now, in glaucoma, because of corneal edema, the slit remains intact. It will not break. Whereas in cataract, the slit is broken. And to differentiate between the acute conjunctivitis, after wiping off the discharge, micropyridine discharge, the colored halos are like they are gone. They are not there. So later we'll come down to these two differentials, where we can differentiate by Fincham test.
So what is the basic mechanism behind those colored halos? What is the actual physiology behind it?
The fluid accumulation will cause the different refractive indices, which will cause the
Diffraction of the light is happening because of
What is
the
that effect called as?
diffraction of light.
Diffraction of rays because of the prismatic effect.
In glaucoma, it's because of the corneal edema. In cataract, it's because of the hydration of the lens, and because the hydration of the lens has different causes a variation. It's not uniform. That's why there's a splitting of the light.
Okay. So what is the importance of history of using glasses? Is there any difference?
Since this was a painless loss of vision, which was gradual and progressive, one of the differential we could think of is like refractive error. So history of glasses was for that.
And also, ma'am, in patients with glaucoma, the patient will have a problem with accommodation. So, and also patient will get confused between the restriction of the peripheral field of vision with the diminution of vision. So he keeps changing the glasses. So that's why we ask for history of using glasses or any frequent change of glasses.
Yes, frequent change of glasses is important. So how do you differentiate the photophobia in case of glaucoma? So you are asking about the redness, watering, and photophobia. Is there any difference between the photophobia caused by glaucoma, or is there any difference caused by some ocular surface disease? Photophobia.
Sure.
So where do you see photophobia in glaucoma?
In acute
Angle closure.
angle closure, we do see.
And there is a corneal edema, high rise of
Yes,
intraocular pressure, you can see photophobia,
ma'am.
where the patient is having sudden loss of or diminution of vision.
Okay.
So, when will you expect headache, nausea, and vomiting?
That is to rule out acute angle closure. So acute angle closure glaucoma is associated with headache, nausea, and vomiting.
Okay. So, when do you expect that one? Is there any pressure range? More than that, you can expect nausea and vomiting.
14 millimeters of mercury mostly causes the nausea and vomiting associated with it.
I can't able to hear you properly. Is it audible to others?
Yes, ma'am.
Okay.
More than
More than 40 millimeters of mercury will mostly cause the nausea and vomiting along with the headache.
Maybe in acute angle closure glaucoma, the mechanism is different. So it causes more of because of the severe pain and this thing, the patient will feel nausea and vomiting. But in NVGA or other conditions, even if the pressure is more than 40 or 50, so it won't cause any nausea, vomiting. Only especially in acute rise, post-operatively because of the pupillary block and all, or acute rise because of the acute angle closure attack, we will expect nausea and vomiting. But other conditions where there is a gradual rise of IOP, where if it is more than 40 also, we won't expect any nausea or vomiting. But here, acute attack, we will expect. So what is the differential diagnosis for the acute angle closure glaucoma? Acute headache.
For
What are the two differentials?
If it is associated with severe headache, a migraine can be suspected, or nausea and vomiting in any
No, I'm not
intracranial.
talking about the nausea vomiting. I'm just asking what is the other differentials for the acute angle closure attack. If the acute red eye is there, so what are the other causes of acute red eye?
Acute anterior uveitis, acute conjunctivitis.
So there is a beautiful table in Parsons, the differential diagnosis of acute red eye. One is the acute angle closure glaucoma, and second one is the conjunctivitis, third one is the uveitis, anterior uveitis. These three are the differential diagnosis for the acute red eye. Okay, next, move on to the next slide. So whenever you are writing anything, you already explained nicely what are all the differential diagnosis in the history itself. Okay, going back to the past history. So the patient already had the history of injury in right eye. So what do you expect in left eye?
Sympathetic ophthalmitis. Sympathetic ophthalmitis can happen.
It can happen, but is it so sudden?
It's
Or is it gradual?
It is not gradual.
So what is the reason for the sympathetic ophthalmitis?
The trauma to the other eye, since the eye is an immune privileged site, when there is trauma to it, then the antigens are, the body is exposed to the antigens, and this causes, because of the breakdown in the blood barriers, and because of this, there's sensitization, and there can be like an immune related damage to the other eye. The sympathizing eye.
Okay. Next slide. You
Personally,
don't want to ask any other history other than present history and past history?
family history, systemic history also will.
Okay.
So in the personal history, the patient, there was no ill habits, and the other
What is meant by ill habits?
Tobacco chewing and all can also cause tobacco and smoking can also cause gradual loss of vision.
Tobacco gradual loss of vision also.
Is there
Okay.
So
And what are the other things? Only tobacco chewing.
tobacco
Other
chewing?
than
Other than that, the other ill habits that can cause.
what other ill habits I am asking? So alcohol, methyl alcohol poisoning. So alcohol adulteration again causing the features which are similar to which mimics glaucoma. So that's why it's not ill habits, it's the alcohol or the smoking which can cause the similar conditions which mimics glaucoma.
Hmm.
Okay. Is there any relation to the sleep pattern?
To the sleep pattern, there can be if the patient is hypertensive and they're on hypotensive medication, but they're on medications, then there can be nocturnal hypotension, which can be one of the causes for the
So that is
IOP.
important, the nocturnal dipping. So
Nocturnal.
nocturnal dipping. So especially in normal texture glaucoma,
glaucoma is most
nocturnal dipping will cause low ocular perfusion. Again, that will cause ocular ischemia and the further progression of glaucoma. Okay. What are the other things in your slide? Normal appetite, normal bowel and bladder habits. Is there any relation? So normal appetite, normal bowel and bladder habits are okay, but the patients with chronic constipation, it's not really related. But the thing is, whenever we are planning for a surgery, we need to ask that history also. Or otherwise, here in Andhra, we used to ask excessive intake of water in the personal history. So if the patient is taking half liter or 1 liter of water early in the morning to regulate their bowel and bladder habits, so that will cause sudden rise of intraocular pressure. It is nothing but water drinking test, but the pressure in not in all patients, but out of 100 patients, some 2 or 3 patients will have that rise of intraocular pressure, which can cause damage to the optic nerve. So that's why we used to ask any excess intake of water in the personal history itself. So one more thing here we used to ask is history of yoga. So history of yoga, the tilted postures like Shirshasana and Sahasrasana. So these tilted postures will cause sudden accumulation of the blood and the rise of the episcleral venous pressure, which can cause obstruction to the outflow. So that can cause raise the intraocular pressure and causing glaucoma. So these are the personal questions we used to add in the personal history. Okay, next.
There was a systemic history. The patient is not a known case of diabetes, hypertension, asthma, or heart disease, and is not on any medication. And there are no significant vision loss in any of the other family members.
So why is the history of asthma and heart disease is important?
Asthma and heart disease, since if we take up the patient for surgery, then that becomes an important history.
And also for medical management of glaucoma, we need to specifically ask for asthma and heart diseases to avoid certain drugs like beta blockers and all of that. If they are already on beta blockers systemically, then there is no point in adding the topical beta blockers. And asthmatic patients to avoid beta blockers, and in sinus bradycardia patients, we need to avoid all the beta blockers.
Yes, those are the very important history. Whenever you want to write any beta blocker for any glaucoma patient, first thing is we need to check the pulse. So the bradycardia patient, especially while surgery, you can note down the pulse rate will be going to 50 or 40 or something like that. So when the patient is having already bradycardia, if you prescribe beta blockers, that will again induce another episode of bradycardia. So those patients we should avoid. And the asthma patient, we feel that only one drop the patient is using, but the nasal mucosa is very rich with the vascularity. So whenever even the drop of one single drop of beta blocker can cause sufficient levels in the systemic circulation, which can cause severe acute asthmatic attack. Same like heart patients, second and third degree heart block patients, it can cause sudden myocardial infarction and shock. The patient may go into an acute MI attack. Okay. So these patients, we should always ask the patient whether they are asthmatic or patient is having other problems like second or third degree heart blocks kind. So are there any other conditions in his systemic history we should consider?
Renal problems also we need to ask them.
Which one?
Renal diseases, like any renal issues they have, or if they are have any renal problems or liver hepatic diseases like that, because drugs.
Those are the rare things which we can encounter, but the normal things like antipsychotic medication, so which can cause sudden bilateral acute attacks, are the antihistamines. So especially those who are prone for the angle closure attacks, like the patients with narrow angles. So we need to ask for the history of any usage of any other tricyclic antidepressants if you want to prescribe any alpha agonist kind of medication. So we need to check all the medications before coming to the conclusion. Okay. And then family history. How the family history is affected?
One more I'm adding.
Okay.
Topiramate that we use in migraine also, you have to ask the patient. That may also cause the shallow ACs and all. But PI doesn't work in that condition. And one more thing is history of usage of steroids for any cause, like skin disorders or joint pains, and any renal transplants and rheumatoid arthritis. All those steroid history also you have to take properly, because steroid induced glaucomas and cataracts are common. Here in our area, it's very commonly seen thing in our OPDs. So never forget to ask the history of steroid usage.
Any form. It may be ointment form near the skin, on the face, or it may be an injection form, or it may be topical drops. But most of the time, the topical drops are having the high response rate, but others also, the systemic and the other routes of administration also we should consider, and we should ask for the steroid history. So nice point madam mentioned. And then family history, how it is affected.
Family history, if certain conditions are genetic, so they run in family and there's a familial pattern. So we can see if any other family members had, for example, glaucoma. And secondly, if suppose one of the family members has got very severe form such that they've had almost like a blind eye, then we can, it just gives an idea that it's a more severe form.
And we can screen the kids and the siblings also if they're.
How the risk will increase in if the family members are having glaucoma, how the risk is increased in the patients. So most of our patients, if the mother or father is having glaucoma, or sister or brother is having glaucoma, if they come to us, how do you counsel the patient?
We will recommend screening for glaucoma in the patient if they have a family history, and if
do you consider if the mother is having, the risk is more if the mother is having glaucoma or if the sister is having glaucoma?
If the sibling has, there's a higher risk, higher percentage of risk than if the parents have.
Yeah, if the siblings, if the brothers or sisters are having glaucoma, the risk increased by 9-fold. If the mother, parents or grandparents are having glaucoma, the risk increased by 5-fold. So always the siblings risk is more important. So if any of the siblings are having glaucoma, so always you need to check for other siblings also, so that you can able to find the glaucoma in an early stage in the siblings. Next.
So whenever patient comes to you having glaucoma, you have to counsel them like in such a way. If you have glaucoma, and you have to explain clearly the percentage, like fivefold for the parents and 9% for the siblings. If you tell the percentage of the risk factor, then they will that will become an alert thing for the patient, and they will go for the follow. Okay.
Next. Next.
Next.
So, ma'am, our differential diagnosis for this patient is glaucoma. Then the different forms of glaucoma, like pseudoexfoliation, primary open-angle glaucoma, then uveitic glaucoma, then yes, cataract, refractive errors, and so. Should I move on to general examination?
Yeah. General exam.
The patient is conscious, cooperative, well-oriented, and afebrile. Pulse, blood pressure, respiratory rate was all within normal limits, and there was no pallor, icterus, cyanosis, lymphadenopathy, or edema. Ocular examination, the head posture was normal. The ocular position, the left eye was orthophoric, and the facial symmetry, is symmetrical. The vision, in right eye, the patient only had perception of, the perception of light was absent. In left eye, the uncorrected visual acuity was 6/60. With pinhole, it improved to 6/24 parts. The best corrected visual acuity was up to 6/24 parts, with minus 4.5 spherical and minus 0.5 cylindrical at 90 degrees. Near vision with +2 diopter sphere, the patient was reading to N24, and extraocular movements were free and full and free. This is the slit lamp photo. So this is the right eye, and this is the left eye. The right eye, there's phthisis bulbi. The lid and adnexa, the right eye and left eye both were normal. I'll finish the right eye and come to the left eye. In the conjunctiva.
How will you check for the perception of light?
We have to use a dark room, and we use a torch, and perception of light, we check in different quadrants. We use the ray.
We just ask the patient if he can perceive the light or not, and after that, if depending on the response from the patient, if there is perception of light or not, then the next step is we'll go to the projection of rays in all 4 quadrants.
So if the perception of light, if you want to examine with the torch, then if the torch is not bright enough, then what do you want to do?
You can use IDO also.
So the brightest light possible, which is available in the indirect ophthalmoscopy light, you can use that, and you can check the perception of light if it is present or not. If the perception of light is there, but projection of rays is not there, so what is your inference?
The central macular retina is attached, and the surrounding the peripheral retina is detached. So that's why it is.
It's not related to the retina detached or attached, but it's like the explaining the visual prognosis. If the PL is present and PR is not present, so the chances of getting good vision after surgery or after the whatever procedure, not in this case because already thistle eye. So other cases, if the intact eye with the opacity, corneal opacity, or the dense mature cataract, if the perception of light is there, but the projection of rays is not there, so the patient may not able to get a good vision after surgery. So you can't assess the vision in a mature cataract at the media opacity. So in those cases, if the projection of rays is not adequate, then the chances of getting good vision is guarded. So you need to explain that by doing perception of light and projection of rays. Okay. Coming to the left eye.
One more thing. The vision is 624 in the left eye now with correction. What is the significance of that? Like, is there any, like, obviously the patient is having cataract. Any visual significance? Vision with pinhole correction is 624. Any importance is there or not? For that, you want to proceed for the cataract surgery. What is the cutoff for the vision, especially in one-eyed patient? If the patient is having better than 618, you should not go for the surgery, especially in one-eyed patients. But if vision is worse than 618, then you can go for the surgery. There is generally a rule for one-eyed patients. Okay, proceed.
In the right eye, the lid and adnexa was normal. There was phthisis bulbi and the cornea had vascularization. The left eye, lid and adnexa was normal. Conjunctiva, there was a grade 1 nasal pterygium present. Cornea was clear and anterior chamber was Van Herrick's grade 2. There was no cells or flare. The iris in the left eye is there was a normal iris pattern and there was no neovascularization of the iris. Pupil was 3 millimeters, round, reactive, and regular. Powdery-like material was deposited at the pupillary margins. Normal pupillary reflex, direct, was present. Direct and indirect was present. The lens, the cataractus lens, there was a nucleus sclerosis grade 2 with posterior subcapsular cataract. On checking the intraocular pressure, which we use Goldman applanation tonometry to measure, the left eye pressure was 28 millimeter mercury at 8:30 am. On gonioscopy, using the 4-mirror gonioscope, in the left eye, pigmentary tabular meshwork was seen in all quadrants, which was suggestive of open angles.
So what was the grading system you were using for the gonioscopy?
Use the.
You need to tell which grading system you are using.
The Schaffer's grading system.
Schaffer's grading system. So is it open angle or closed angle?
Open angle.
Open. What is open angle?
Based according to the Schaffer system, we have if there is grade 4 and up to grade 2, it is open angle where we can see the posterior tabacular meshwork till then. And if it is grade 1, then you can see only the short baseline, and grade 0 when
No,
one.
here what is your grading? I'm not asking about the total Schaffer's grading. I'm just asking what is the grade you are giving in this case.
Grade 2, ma'am.
Grade 2. Okay. So you can see trabecular meshwork in all the angles, posterior trabecular meshwork. What are the other things you can expect in this case? Other than this?
You can see the sample ACs line also. And if not particular, it is not, and also dense pigmentation of the trabecular meshwork also I can see.
Most of the times you can see dense pigmentation as well as the sample ACs line. What are the other things you can expect?
We can also see the dandruff-like material in the angle in the angles on gonioscopy.
What are the other places where you expect this dandruff-like material?
Starting from the conjunctiva, there can be deposition in the conjunctiva. then cornea on the endothelial deposition can be there. And then iris, anterior chamber also, there can be powdery material which can mimic like cells and flare. And angles, posterior, trabecular meshwork, it can get deposited. And on the iris, it the pupillary border, it can get deposited. And on the lens, sorry, ma'am.
What are the other features you can expect in pseudoexfoliation?
Other features, ma'am. Sorry,
Ma'am, it wasn't clear.
ma'am, your voice broke.
What are the other features you can, what are the other signs you can see in pseudoexfoliation?
We can see the deposition even on the capsule of the lens, which is a bullseye pattern.
And on the cornea, we can see there is endothelial decompensation, and there is polymagatism and deposition of the
Do you expect
pseudoexfoliation.
crooked spindle in pseudoexfoliation?
Pupillary spindle is seen in pigment
dispersion,
it's seen in pigment dispersion syndrome more commonly.
That is all. You can expect pigment dispersion as well as in pseudoexfoliation. In both the conditions, you can expect crooked spindle, and added to that, you can expect some deposition of the pseudoexfoliative material on the endothelium as well as the low endothelial count. So before going for a surgery, you need to do a specular count for all the pseudoexfoliation patient.
Yes.
And what are the things you can see on the iris?
On the iris, at the pupillary margin, we can see the powdery powdery deposition along with the loss of the pupillary ruff, which gives that moth-eaten appearance, along with the peripupillary border transillumination defects also.
Those are important. The pupillary transillumination defects. What is the importance of that transillumination defects? Why those happen?
Ma'am, because of the degradation of the iris tissue, and along with the sphincter muscle atrophy, this transillumination defect occurs, which leads to poor dilation of the pupil.
Because of the rubbing of the posterior iris surface onto the anterior lens surface, there is a loss of pigment cells causing transillumination defects, and the moth-eaten appearance and the loss of pupillary ruff, which is causing loss of sphincter muscle, finally resulted in poor metiasis.
Okay.
Next. So what happened to the zonules? Can you see zonules here?
Ma'am, we could not
see the zonules, but there's also weakening of zonules that happens, and because there's also deposition of the dandruff-like material on the zonules.
So that can lead to phacogenesis and subluxation or dislocation of the lens also. And during cataract surgery, it it is a matter of concern during cataract surgery, and we have to be very careful during exercise.
Actually, this is new theory. So that is like the presence of brownish pigments in the anterior lens capsules along the zonules, which is known as the brown pigments in PXF. So usually the PXF material is white in color or powdery. But the Narayan Nethralaya people, they did one study, and they were telling that the brown pigments in the anterior lens capsule were the brown pigments in the pseudoexfoliation. So that is nothing but pseudoexfoliation, which is brown in color. So there is an anterior insertion of the zonules also we can expect in this pseudoexfoliation. So that's why whenever you see any patient with brown pigments on the anterior lens capsule, while doing DEXIS, you need to be cautious, otherwise it will run away. So when you see that brown pigments in the anterior capsule as well as the poor mydriasis, the chances of running away of the rexis while doing rexis as well as chances of echodonosis and chances of jonular dialysis on table are very high. So those patients you need to be more conscious when compared to the other patients. Okay.
But then the brown pigments, like how to differentiate with the iris pigment deposition, like any other.
Those are not the actual pigments. You can see if you see the brown pigments on the anterior lens surface in the mid periphery, not in the far periphery, not in the center. If it is in the center, those may be because of the some synechiae or some other thing. But you can see if the brown pigments are there, they are like a jonules, how they inserted onto the anterior lens capsule. You can see like the lines of brown pigments. Then you can say that those are the brown pigments because of the pseudoexfoliation. Next.
And what is the cause for weakness of the zonules in pseudoexfoliation? What is the mechanism?
Ma'am, the proteolytic enzymes, because of the PXF material, it causes zonular
Degeneration. Yes.
cause the
The
zonular.
proteolytic enzymes that are present in the PXF material will cause zonular degeneration.
Yes.
The matrix metalloprotease.
Okay. And one more thing is, if the patient is having PXF material in one eye and no PXF in the other eye, but still there is a chance of developing PXF in further. Or how can you identify like any early signs that can be that you can say PXF may develop in this eye also?
Earlier sign, clinically, we can see based on the deposition on the zonules in UBM, if we get UBM, and also the conjunctival biopsy also detects the early deposition of the
No, by examination I'm asking.
usually,
Not the UVM, but slit lamp examination. Is there any clinical signs or anything that you can identify PXF may develop in the other eye also?
Not sure.
Endothelial cell count will give some clue that that patient may develop PXF in the other eye also. And one more thing is the pigment, heavily pigmented trabecular meshwork will also give a clue that that patient may develop PXF in the other eye, PXF syndrome. Okay. Next.
Coming to the fundus examination, left eye, the fundus media was hazy. Then coming to the disc was so normal in size and shape, and it was showing the 0.7 cup disc ratio with the superior thinning with peripapillary atrophy. And the arteries, blood vessels are rising from dichotomously with 2:1 ratio. Macula, the foveal reflex was dull, and the rest of the retina, peripheral retina, was looking normal.
So what do you want to do with this case? Neha? Please
So,
proceed with this case.
so this appears to be a case. I mean, the patient appears to have pseudoexfoliative glaucoma. So, to proceed, we will do further investigations and then see for the management.
So actually the chronic cause should go first. So the pseudoexfoliative glaucoma with senile immature cataract would be the diagnosis. So in this case, because the pressure is high, 28, but the vision is 624. Can you advise any visual fields for this patient?
So
Vision,
vision should be 6/6 to do the HFA.
6/6.
Yes, ma'am, we can proceed with the HFA because the minimum vision required for HFA is 6/60.
Less than 6/18, you may expect some low reliability for this patient. But as for the fundus you are showing, there won't be any macula split or macula thread. So with the pressure of 28 and with the vision of 624, you can try to do a HFA. And if the HFA is showing some inferior arcuate scotoma because you are showing superior NRR loss, so which is not threatening macula, so you can proceed with the surgery. So what are the drugs of choice for this patient? What do you want to prescribe?
Ma'am, my first preference will be prostaglandin analogs.
Why?
Because it has very less systemic side effects and they are more effective. The IOP reduction and everything is like 20 to 30% of IOP reduction is there. So first preference will be prostaglandin analogs now.
So what is the action of prostaglandins?
It increases the uveoscleral outflow. So
what is the mechanism underlying increase of the uveoscleral outflow?
Prostaglandins will cause this increase in the the spaces
Matrix.
matrix.
It increases the synthesis of matrix metalloproteases and increases the uveoscleral outflow, and which is like
So
a
what is the pathology of pseudoexfoliation?
Basically, the opening triangle glaucoma, which is most common variant associated with pseudoexfoliation, causes because of deposition of this pseudoexfoliating material in the intratabacular spaces and meshwork. Most
Yeah,
common.
at the cellular level. I'm asking at the cellular level. It's the same. It is the because of the changes in the matrix metalloproteinases and proteoglycans. So same action we can expect with the prostaglandins. That's why prostaglandins are the treatment of choice in pseudoexfoliative glaucoma as well as pigmentary glaucoma. So it acts on the direct pathology of the pseudoexfoliation glaucoma. There is a beautiful chart of pathology of pseudoexfoliation glaucoma in shields. You can read that one. So these prostaglandins will directly act on the pseudoexfoliation pathology so that it will increase the uveoscleral outflow and it will reduce the intraocular pressure. So with the single drug, can you able to reduce the pressure in this patient?
Most of the time they are resistant to single drugs, so we'll have to use 2 or more drugs. So a combination of prostaglandin analogs and beta blockers.
And also, I would like to measure the intraocular pressure very often at different timings because the diurnal variation is more with pseudoexfoliative glaucoma. So based on that, we can combine the we can have combination medical management. Since we need to
this patient is one-eyed patient. So how do you proceed with the surgery? You want to do a single surgery or a combined surgery?
I'd like to go for combined surgery, ma'am.
Why?
Because the vision can be improved. The vision is improved much better with the combined surgery, and the patient will have better prognosis and the healing also very.
So post-operatively we will use cyclophysics and all. So vision won't be that great post-operatively if you do a combined surgery. If you do a simple cataract, we won't use any cyclophysics post-operatively. So that is much better. So the visual rehabilitation is much better with the single surgery like cataract surgery. But the visual rehabilitation after combined surgery or the plain trabeculectomy is not there. It's not comparable to a simple cataract surgery. So for this patient, for 28 pressure, one thing is you can reduce the pressure over a 3 weeks period, and then you can go for a combined procedure because the patient need at least 3 drugs to reduce the IOP to the level of 14 to 16. Because the patient is one eye, so we can't risk the single-eyed patient. So this patient, at least 3 drugs are needed to maintain the pressure. So applying 3 drugs every day is very difficult task. For that, anyway, the patient is having cataract. So we can reduce the pressure over a 3 weeks period. And if the pressure reaches to the target pressure like 14 to 16 or 16 to 18 for this patient, then you can go for combined surgery. So if the patient wants early rehabilitation, early visual rehabilitation, if the patient doesn't want any post-operative, if the patient not able to come for the frequent follow-ups post-operatively, then you can do a plain cataract surgery and you can advise the anti-glaucoma medication. Okay. Or if the patient wants, I want to go for combined surgery, you can do combined surgery. So,
What are the precautions you have to take while doing combined surgery?
Since the pseudoexfoliation is it's a risk for complications during cataract surgery because there is zonular weakness. So we'll have to keep other aids ready, like for example the iris cloth and CTR
and starting with the because the corneal endothelial density will be less. So we can use the Viscoat to prevent further loss of endothelial cells. And then for poor mydriasis, and we can use iris hooks and we can use Marucan rings and all of that for pupillary dilatation. And during rexus, we have to be very careful because there can be extension of the rexus also. And if there is phacodosis or zonulopathy, then we can use those capsular tension rings. And with the IOLs, coming to the IOLs, we can use 3-piece IOL or we can suture the IOL with all these things.
While doing rexis, better do a larger rexis to prevent the stress granules and to prevent the capsular phimosis also. So rexis while doing, be cautious and do a little larger rexis. And what is meant by soft shell technique?
Ma'am, also known as Ashrinov's technique, where first we inject the viscodispersive OVD, which coats the endothelium. Then in the center, we inject the viscocoercive OVD so that it forms the AC well and we'll have space for surgical space for the instruments.
Finally, how will you differentiate PXF glaucoma from POAG?
PXF glaucoma will? Sorry,
POAG, primary open angle glaucoma. How will you differentiate?
This first of all, patient will not have any corneal endothelial cell loss, and the density will be normal in case of POAG. And also, the pupillary and iris translamination defects will not be there in case of POAG, no POAG case. And zonulopathy and anterior lens signs like target signs and these things will be absent in case of normal POAG.
Just the presence of PXF does not indicate that patient is having PXF glaucoma. It might be a POAG. How will you differentiate PXF glaucoma from POAG? You got my question?
Yes, ma'am. The progression of the glaucoma, the optic nerve damage will be more aggressive and very fast in case. And also, the diurnal variation is more complex.
Coming from the age, it is more commonly, PXF glaucoma more commonly seen above 60 plus age group, and IOP fluctuations are more, and the progression of the glaucoma is very fast in PXF glaucoma compared to the POAG, and the field loss are like disc damage also. Focal loss will be seen in POAG, but diffuse damage is seen in the PXF glaucoma because of the diurnal fluctuations and more progressive damage in the PXF glaucoma and higher IOPs and increased age. These four are specifically for the PXF glaucoma damage. So be cautious while treating any case of PXF glaucoma and ask the patient to come for frequent follow-ups so that IOP fluctuations can be noted and disc damage is also noted at the early stage, and you can intervene accordingly and save the patient's sight. Valis, can you conclude?
This patient of 62-year-old male with gradual diminution of vision in the left eye, with on examination, the anterior segment showed with vision 660 improving to 624 parts, with anterior segment showing the powdery dandruff-like material at the pupillary margin with poor mydriasis. With the posterior segment with the nuclear sclerosis grade 2 with the posterior subcapsular cataract. With fundus examination had 0.7 cup disc ratio with the superior thinning. With IOP 28 millimeters of mercury, and with grade 2 shadow system grading in the gonioscopy. Patient had pseudoexfoliative glaucoma with senile immature cataract in the left eye, and right eye thiacial status post failure.
Okay.
Hello.
Hello.
Malleshwari.
Hello. Finally, want to go for surgery for this patient.
Ma'am, if we look at surgical options when even on maximum medical treatment, we're not achieving the target IOP.
As ma'am said, he will wait for like 2 to 3 weeks. Since the IOP, since the patient is one eye, and this kind of glaucoma needs 2 to 3 medical eye drops. So it's better we go with the surgical treatment.
Reduce the pressure with the help of anti-glaucoma medication, and then maintain the target IOP. Then proceed with the surgery, either combined or a simple cataract surgery in this case, depending on the patient's choice. So, Tejashwini, Radhika garu,
Yes, ma'am.
Yeah, madam, చెప్పండి.
shall we call it a day?
Mama, actually, there
There is
is
a
one.
question. Yeah, Tejashwini, please go ahead.
There is a question in the chat, in the comments from YouTube. So the question is, if we start prostaglandin analogs following combined cataract plus filtration treatment, surgery, the risk of CME will increase, right?
Usually, I won't stop any prostaglandin preoperatively. And the day of surgery also I used to use prostaglandins. But some people will say that the prostaglandins will increase the chances of CMA. But in my cases, I didn't find any of the CME. So I used to use the prostaglandins till the day of surgery. Postoperatively, I won't use it. At least for 1 week, I will stop. If the patient needs anti-glaucoma medication, I'll keep them on oral carbonic anhydrase inhibitors or the alpha agonist with the beta blocker as a treatment of choice postoperatively. But prostaglandins I used to avoid after surgery. But before surgery, I used to ask them to use till the day of surgery also. On the day of surgery also. Hello, is it audible?
Yes, madam.
Okay.
And the chances of inflammation is more in PX of glaucoma. So try to use more of the steroids and NSAIDs also. Instead of using 6 times per day, you can start with 8 times per day steroids, topical steroids.
So here in Shankara Guntur, we have the special regime kind like postoperatively we used to use Nepafenac for 6 weeks. So to reduce the CMA, we used to use steroids for 5 weeks, and another 1 or 2 weeks extra we'll use this Nepafenac, which will reduce the chances of CMA. That's why that may be one of the reason we are very rarely used to see CMAs postoperatively. So preoperatively, I won't stop any prostaglandins, but postoperatively, definitely we'll use these Nepafenac or the bromofenac eye drops at least for 6 weeks. And as ma'am said, if any iris trauma is there because of the small pupil, if the iris is caught into the your phaco probe and all, or if the inflammation is high, if you feel there are more pigments released while doing surgery, then on table we used to give subconjunctival steroids, and as well as postoperatively we used to use escalated dose of steroids like 8 times per day for 1 week, and then taper down to 6, 4, 3, 2, 1 kind of thing. And otherwise, if the surgery went on well, there is not of much of inflammation, then we will proceed with the routine regime of steroid, antibiotic, as well as the Nepafenac combinations. Hello.
Yes, ma'am.
Ma'am, any suggestions from your side to anything we missed and anything we can improve for the next case presentations?
Hello.
Hello, ma'am. Can you hear us?
Any suggestions?
Yes, ma'am. For next coming forthcoming case
No, it was very nice
presentation.
presentations. You both done very nice job. So the discussion also went on well. And that's what there are differences in the local conditions. Like here in Andhra, in certain temperate areas where the humidity is, where the temperatures are very high, like Karnagiri and area.